Good afternoon. Thanks so much for joining us for today's web chat for Florida Hospital. I'm Jennifer Roberts. Today we're going to be taking on the topic of male and female infertility. Don't just have one great doctor to talk to you today. We've got two to talk to you about this issue, one from the women's perspective and one from the men's perspective. So hopefully we'll give you a lot of well-rounded information out of today's chat. Dr. Zamip Patel is an andrologist at Florida Hospital East Orlando. We're going to talk to him in just a few minutes, but first up, we're going to talk female infertility with Dr. Sejal Patal from Florida Hospital Celebration Health. Now, these doctors are going to take your questions over the next 20 minutes. So both the doctors are in, so let's get things started right away. I want to welcome Dr. Sejal Patel. Thank you so much for joining us.
Thank you so much for having me here.
Absolutely. Let's get to the very, very basic questions about female infertility. How do you know when you're having problems getting pregnant?
It's a great question. So infertility should be something that is very simple, something that's not very well thought through. But if you are having trouble conceiving, you're having unprotected relations, and you're under the age of 35, and you've been trying for more than a year, there may be an organic etiology behind your infertility. If you're over the age of 35, and you've been trying for 6 months or more without success, this doesn't mean you're checking for ovulation, you're trying to find the perfect time. These are random acts of intercourse and you're not successful. There may be a pathology or some organic etiology behind your infertility. If maybe you don't have very regular menstrual cycles, they're not between 26 to 34 days, that may be a clue. If you have a lot of pain during your period, during intercourse, that may be another clue. That there may be another etiology behind why you're struggling to get pregnant.
Yeah. So obviously there are so many factors. You just listed a few of them. When is it time for someone to say, okay, we really are trying to get pregnant and we're not having success? When is it time to seek out someone like yourself?
I think it's a great question. So if you're under the age of 35, you have regular menstrual cycles, no other endocrine or GYN disease, and you've been having intercourse for about a year unprotected and you've not been successful, you should seek out a consultation with a reproductive endocrinologist. If you're over the age of 35 and it's been more than 6 months, because of your age, typically we would recommend that you see a reproductive endocrinologist at that time frame. And then, of course, if you had irregular cycles or pelvic pain or any other unusual symptoms.
Is it, a lot of times I think when couples are experiencing infertility, the women always think it has something to do with them. Is there really any truth to that, or is that kind of all up here in between our ears?
It's amazing how female infertility accounts for 60% of the diagnoses behind why a couple may be struggling to start their family. But male infertility accounts for about 40% of the various etiologies, so it's just about half and half.
Half and half. So it could go either way. You don't have to put all the burden on yourself. What are some of the are there things that women can do to help themselves in the early stages to help them get pregnant, maybe even before they pick up the phone and call a specialist? What are some of the things you might recommend?
Sure. So our National Society, the American Society for Reproductive Medicine, has actually published guidelines for improving your fertility naturally. Items that we would counsel patients on in the office include being at a very healthy weight. Calculating your BMI based on height and weight. You can just plug that into any computer program and it'll give you an answer, and you want your BMI to be between 19 and ideally 34. Women who are significantly underweight or women who are significantly overweight or obese have a decreased likelihood of being able to conceive per cycle. Additional items, caffeine utilization, decreasing that to as minimal as possible if it's necessary. No alcohol, especially after you've ovulated. Limiting it, if not being able to completely, eliminating it in the first half of your cycle. Obviously smoking, minimizing the number of medications you're on, making sure the medications that you're taking for other medical problems are safe in pregnancy. Those are all very important. Trying to minimize your stress, something that's very easy to say, very difficult to do.
Yeah.
We know that has a significant impact on your fertility. being able to achieve at least 6 hours of sleep per night. Those are probably the best tips I can give you for optimizing your fertility naturally. In terms of being able to optimize your chance of conceiving every cycle, there are things that you can do at home. There are ovulation prediction kits that you can buy just over the counter. They pick up on your LH surge, which is a surge that occurs about 24 to 36 hours before you ovulate. And so you can use that to help time relations. After relations, lying in the same position for about 10 to 15 minutes is plenty sufficient. Those are some of the kind of more technical scientific things that you can do to optimize your chances of fertility every month.
Great. And so let's say we've gone through the natural route and we've hit some of those thresholds that you said that you may be having an issue. When folks come to you, what kind of options? I mean, I know a lot of people just think, okay, in vitro, and that's kind of like, that's way down the road. There's other things that you're going to talk to folks about in the office before you go there.
Absolutely. So when a couple comes into the office to see us, we do a very holistic history, physical exam. We try and identify risk factors or clues that would give us an idea as to what might be causing their infertility. And then we typically do testing. We're looking for eggs, how well ovulation is occurring with those eggs, how receptive is the reproductive tract, are there other factors, either anatomically or from an endocrine standpoint, hormonally, that may be contributing to their infertility. Once we've done that testing, depending on what we find, would dictate our treatment. If we find fibroids, maybe we're doing a robotic myomectomy. Endometriosis, maybe we're removing the endometriosis. If it is a subtle male factor or it is an ovulatory dysfunction, maybe we're putting them on mild fertility pills. Maybe we're using artificial insemination to time conception appropriately, and that's where semen is processed. The most directionally motile sperm are placed directly into the uterine cavity, very gently, in order to optimize the chance of conception. If pills, injections, insemination aren't successful, then we do have more advanced technology like in vitro fertilization. With in vitro fertilization, we can freeze eggs electively. So let's say a couple is trying to conceive, but let's also talk about a woman who maybe isn't ready to conceive but wants to just preserve her fertility. We can freeze her eggs. If a couple's attempting conception and needs in vitro fertilization, but maybe they have a family history of cystic fibrosis or they're both carriers, we can now do genetic testing on a day 5 embryo and eliminate their risk to less than 1% of having an affected child with cystic fibrosis or spinal muscular atrophy or anything that is identifiable through a gene.
And so obviously there's a lot of different steps. I know people sometimes get nervous when they talk about some of these treatments and cost. What is it, I know insurance is covering more and more of these procedures all the time. Talk about what people should expect.
That's a great question. So in our area, interestingly enough, about 40% of insurances will have some form of coverage. Diagnostic testing, treatment, in reference to inseminations or in vitro fertilization. So the most ideal thing is once you've determined that you need to see a reproductive endocrinologist, be as proactive as you can be and identify from your insurance provider what is covered and what is not covered. In our specialty, we're very aware of the fact that most patients don't have coverage, and so we're very thoughtful in our approach. We can think outside the box if we know ahead of time what the patient's limitations are, whether they're ethical, religious, fiscal, timing. So from that perspective, the more proactive you are with knowing what your coverage is, the better able we can work within your limitations to make sure we help you achieve that goal of being successful and having a healthy live-born baby.
Yeah, fantastic. So, and one other thing I wanted to get to, sometimes it's very difficult and maybe folks might worry about, is this infertility treatment going to work? Is there some treatments that are more successful than others, or what kind of prediction can you give somebody? And certainly we know you don't have a crystal ball too.
It's a great question, and of course that is what everyone is looking for, is the hope and the knowledge and the reassurance that we are going to be successful. I can assure you, using all the technologies we have available to us, probably 97%, 95 to 7% of couples will leave our practice with an ongoing gestation if they can follow through with all the treatments. There are limitations along the way that clearly would impede it. Depending on the treatment, going back to your original question, that would determine success rates. The less invasive a treatment is, the lower the success rate initially. Over multiple tries, that cumulative success rate can be really high. With a more aggressive treatment like in vitro, pregnancy rates are significantly higher. But it does depend on what the etiology is behind the infertility. In vitro isn't for everyone, as you very appropriately said. Sometimes it's surgery, sometimes it's correcting an endocrine disease, high levels of prolactin or abnormal thyroid function. Sometimes it's just an artificial insemination.
Yeah. Well, Dr. Patel, thank you so much for your time here. Dr. Patel is a reproductive endocrinologist. Great information about female infertility. And of course, we're going to get to the male side of infertility with Dr. Zamip Patel in just a moment. No relation, by the way, after just a brief break.
Imagine living a healthy 100 years. At Florida Hospital, our innovations in cardiovascular care can help make it happen. What do you want to do when you're 100? Visit healthy100.org.
Thanks so much for staying with us. And joining us now, we have Dr. Zamip Patel, an andrologist at Florida Hospital East Orlando. He specializes in treating a variety of male infertility issues. Welcome, Dr. Patel, and tell me, what causes male infertility?
Well, generally speaking, when we talk about male infertility, we talk about 4 general classes. We talk about genetic reasons, we talk about hormonal reasons, we talk about environmental reasons, and we talk about anatomic reasons. Now, within each one of those subcategories, there are certainly different things that we would do based on which one somebody would fall into, and they're not mutually exclusive. So someone may have a combination of those things.
And we learned from Dr. Patel just a few minutes ago, 60% of the time it's a woman's issue, but 40% of the time infertility can be a man's issue. Do you find that men often think it's their infertility that's causing the problem?
So that's a really interesting question.
Yeah.
And if I had half an hour, I could spend that whole half hour talking about that. But in a nutshell, it has a lot to do with the way our societal norms are. And not just ours, many different societies. So yes, unfortunately, the onus of fertility oftentimes falls on the female companion. Having said that, as Dr. Patel had accurately said, that's not the case. And oftentimes it is the case where it's not one or the other, but both.
But both, yeah. That's the double whammy, right?
Yeah.
What are some of the signs that a man should visit a specialist, someone like you, in the case of infertility if they're having a hard time getting pregnant?
So usually what we say is exactly what Dr. Patel had said, that after a year under the age of 35, after 6 months past the age of 35 for the couple, usually what we do is do both a male and female workup because, as you accurately stated, we don't know off the top of our head which one it is, and oftentimes it is both. So usually what we say is the same sort of things that go for the female, go for the male, go for the couple. And usually that's the way we try to approach infertility, is not just one versus the other, but certainly as kind of a, as Sejal had actually accurately said, it's kind of a holistic approach, not only approaching all the factors that may be for the female, but certainly for the male as well.
So it's definitely something that you could recommend people going at together. Like this is a process that's not just the woman's going to go in and the man, is going to wait and see. You advocate for the couple to do this together.
Certainly, the best outcomes come from the patients that both come in together, and not only because they're both involved and they're both engaged, but also so that they can both understand what's going on, and that creates less friction at home and less of the idea that it is one versus the other. When it comes to infertility, it is kind of we're in this together. And so oftentimes for myself, I get the most pleased when I walk into a patient's room And both the male and the female are there because not only are we able to get a better understanding of what's going on, we're also able to kind of explain things a little bit better to both sides of the coin.
Yeah, it makes sense. Talk about some of the treatment options that are available for men at this point.
So again, it goes back to what the reason is for the infertility, but there are surgical ways to correct either possible genetic input as far as the reason for male infertility. Also for patients that had previous vasectomies that have actually caused the infertility themselves, there are ways we can surgically correct that, even at very late stages after the vasectomy. There's also different types of hormonal manipulations we do, so things like pills, injections, things like that may help to actually spur sperm production. And then we also kind of do a thorough workup in terms of what the patient may be doing right or wrong in terms of their home environment that may be kind of detrimenting their sperm production. Sperm is one of those things that's acutely sensitive to the environment. Little things can really make a big difference.
Wow. We do have a question. It's actually for a female. It's a female question, but I wanted to pose it to you while you're here anyway. So we have a woman who has PCOS, maybe you know what that is, hyperthyroidism. Sorry, it's an acronym. I'm not used Clomid for 6 months, but had cysts and issues with that option. Other options before IVF. So I don't know if that's a Dr. Patel question. If we're going to be able to, I know I don't have a mic for her right now, but
that's probably more appropriate for
Dr.
Patel.
The other Dr. Patel, right? Got it. Okay, we'll try and see if we can get that question answered. Probably when we get after the show and get Dr. Patel to maybe type in an answer there. So some of those options, I know you were talking about sperm and some of the things. So explain what are some of the things that are impactful. That maybe some of the things that we should think about, but maybe folks before even coming to you.
So certainly some of the things we talk about are things you can be doing, not be doing in terms of, well, exercise for one. We say a moderate amount of exercise is good. And as Dr. Patel had accurately said, what we're looking for is a BMI less than about, in males about 34 is about right as well. 32 to 34 is really kind of a borderline sort of scenario. Having said that, too much exercise is bad. So what we want is a slow burn.
Yeah.
Essentially what happens is too much exercise ends up creating sort of a fever environment, and that will drop sperm counts. As far as diet goes, this is something that most would-be parents listen to their real parents, and that is lots of fruits and vegetables, lots of leafy greens. It's probably the only time a doctor will tell a patient it may be a good idea to eat red meat. And the reason for that is because red meat has this stuff called carnitine in it, and there's some evidence that may help as far as sperm counts go. As far as vitamins go, there is a lot of studies when it comes to vitamins, just not a lot of good studies. The good studies that we have show that their impact is, questionable at best. There is one exception to that, and that's coenzyme Q10. 200. It's something that they can find at any store or over the counter, GNC, even online. And what we recommend is 200 milligrams twice a day. Starting that can help. In terms of smoking, of course, that can be a problem, and that can negatively impact sperm counts. But interestingly, different than the female side, alcohol, so long as it's not binge drinking, just a moderate amount of alcohol a day, is okay. There's no problem with that. Caffeine is okay. Again, not in excess.
Yeah, moderation.
Also, even simple things. So things like hot baths, saunas, we tell people to stop that. That can end up heating up the testes, and essentially that can decrease sperm counts. But the typical sort of things that people think of, such as tighty-whities versus boxers, laptops, cell phones, that stuff probably doesn't make too much of a difference. There is some evidence that cell phones may play somewhat of a role, but usually putting it on the side or the back pocket is fine. There's no real evidence that it does too much. So a lot of myth.
Yeah, a lot of myth out there. Yeah, sounds good. Well, thank you for clearing up a lot of those myths. Talk about some of the success rates in treating infertility issues. What can men expect?
So some of this kind of depends on exactly what the other Dr. Patel was talking about, and that is that what we try to do is there are certainly things that we can do for all men, but there are certain things that we like to do to try to make it so that they wouldn't necessarily have to go to an IVF sort of route. So it kind of depends on what exactly is going on with the male. If it's sperm counts that are somewhat normal but somewhat below normal, sometimes it's a simple matter of hormone manipulation or trying certain medications that may be able to increase the sperm counts. If it's an anatomic issue, then oftentimes a surgical correction will do that. Sometimes certain processes that are normally responsible for the normal ejaculatory response, there are medications sometimes that we can do that can counteract that. Sometimes it has to do, sometimes there is, even though we don't see any sperm being produced, that doesn't necessarily mean there isn't sperm production. And sometimes we have these very specific sort of microsurgical techniques that we can actually use to find sperm, whereas they may not be apparent otherwise.
Yeah. What can patients expect? I asked the same question of Dr. Patel about insurance. Is there any, and how people have to pay for some of these type of, different treatment options? Are there, does it differ at all between men and women, or is it pretty standardized?
It does to some extent.
Yeah.
Some of the procedures that I mentioned before, some of them are covered with insurance, some are not. Usually the workup is all covered by insurance, and that includes laboratory values, and that includes some of the basic imaging sort of tests that we would do. Oftentimes when it comes to specific sort of procedures, especially microsurgical procedures, oftentimes those are the ones that aren't covered by insurance. But it depends on the insurance, and we're finding more and more insurances are willing to cover that.
And I kind of wanted to wrap things up a little bit by asking, a lot of people get very frustrated, and I would imagine you see a lot of people, couples that come into your office that are depressed over what's going on with their infertility and that desire to have a child. What would be the kind of hope that you would give folks that are struggling with this issue?
So that's a very valid question. There was a really interesting study done in Scandinavia about 4 or 5 years ago that looked at the biggest stressors between couples. And they looked at the diagnosis of cancer, they looked at a recalcitrant child, they looked at money problems, they looked at a bunch of different things. And what they found was number one on that list was actually infertility. So it certainly is something that can be, to kind of underscore your point, it's something that can be very, very stressful for couples. And oftentimes it can be so stressful that it does lead to a little bit of what you're kind of intimating, that there's just no hope. And if there's one message that I hope to get across, it is that there is definitely hope. There is certainly a lot of things that we can do. And sometimes patients will say, well, I don't want to go through that because it's going to cost too much. And a lot of times it isn't a cost issue. It really is just getting to the doctor and being able to kind of go through the tests that would figure out exactly what's going on. And sometimes it does not have to be a terribly costly sort of thing.
Yeah. Thank you so much for your expertise and taking the time to answer our questions. It was great to have your expertise and have that kind of male perspective as well, because this is almost a 50-50 street, right?
Yeah, it's great to be able to talk about it.
Yeah. Well, thank you so much for joining us. And I know we have gotten some questions actually from folks online. We want to make sure to answer those. Some of them are really specific, so we want to get the doctors online and kind of provide some answers after the chat is over. So we will certainly take care of that. So don't feel like your questions aren't getting answered. We definitely want to do that. And I do want to thank both Dr. Zamip Patel, Dr. Sejal Patel for their expertise on the male and female sides of infertility. If you would like to schedule an appointment with either one of these doctors, you can do that very simply by picking up the phone. You can call 407-303-DOCS, and we can connect you to the right folks that can help you set up that type of appointment. And of course, you can find out more about upcoming web chats. We change topics every month, so you can find out more about those if you like Florida Hospital on Facebook, and also follow us on Twitter. Thank you so much for watching and participating in today's web chat, and we certainly hope that you'll join us again. Bye-bye.